Good morning, everyone. Please come up with queries. I think today there are a lot of doubts. Good morning, Benzeer. Good morning, Anand Ras. So, first question is 51. Okay, so let's start taking first 51. This is 51 question. Bilateral ovarian cancer with ovaries breached, ascites positive for malignant cell. So, what is ovarian cancer staging? Here, I would like to tell you CA ovary stage 1 is that it is limited to ovary itself. Okay, so 1A is limited to one ovary. This is question number 51 which we are discussing. Limited to one ovary, and 1B is limited to two ovaries but capsule intact, and 1C is that capsule has been breached but no other part is involved. Okay, capsule of the ovary is breached, as in this question it was only in the ovarian malignant cells in the ovary, so it is 1C. This staging is 1C, but no other body part involved. If it would have been involved, they would have told you. Okay, so is it clear? Is it clear, Benzeer? Should we proceed? Question number 26. Anand Raj is with query question number 26. History of post-coital bleed. History of post-coital bleed. On examination, cervix is hypertrophied and there is anterior cervix erosion. Yes, so in this question, what is there? That cervix is suspicious, right? Plus the patient is having post-coital bleed. So it's an unhealthy cervix. Okay, so post-coital bleed and suspicious cervix on PS, both of this indicate that this is a patient of CA cervix. So we need to do the confirmative test. Pap smear will not be okay. Is it clear, Dr. Anand? So here we have to do confirmative test. Confirmative test is punch biopsy, or you can say 4-quart biopsy, as in this question no specific lesion is given, so we will do 4-quart biopsy or punch biopsy. If it would have been punch biopsy, it would have been more appropriate. Is it clear, Dr. Anand? Let us take your next query, 28. Here it was 5 centimeter ovarian cyst. Now let me tell you, in this question it was 5 centimeter ovarian cyst. If a patient comes to you with ovarian cyst, okay, then how to treat that patient? And this is question number 28. Okay, how to treat that patient? If that cyst is on ultrasound, that cyst is simple. Okay, and it is less than 6 centimeter, then it means that the problem of that is the hormonal problems. Okay, it means that the problem, the etiology behind it is hormonal derangements. So here you have to give combined oral contraceptive pill for 3 months and 3 to 6 months, and you have to follow up the patient, because the cyst with hormonal dearrangement, they don't go more than 6 centimeter. Okay, so here we are not going to excise the cyst. Another question which has came next is 29. In the 29 question, you can see that the cyst size is 6 centimeter. Sorry, it is something different. One more question has came in today's quiz, in which the size was 6 centimeter. There we have done lap cystectomy. Same question type was there, and there we have done lap cystectomy. Because if the cyst size is more than 6 centimeter, then one has to do it. More than 5 centimeter or has crossed the limit of 6 centimeter, then one has to do it. Okay, let me take question number 55. Next query is question number 55. Which of the following is not a germ cell tumor? Okay, let me tell you, there are 3 types of ovarian tumor. Number 1 is epithelial ovarian tumor. Okay, epithelial ovarian tumor are those tumor which have become tumorous from epithelium of the ovary. Okay, now these epithelial ovarian tumor, they are always mostly they are cystic in nature, and it depends when these epithelium was becoming tumorous, which growth factors have influenced them. Okay, if the you can say, if the fallopian tube growth factor was influencing the tumor when this epithelium was becoming tumorous, then it will be a serous cyst adenoma. And if it is benign, and if it is carcinoma, it will be serous cyst adenoma. Okay, if cervix growth factors have influenced, then it will be mucinous. If bladder growth factors have influenced, then it is Brenner. If endometrium growth factors has influenced, then it is endometrioid. The another type of the tumor is clear cell tumor, whose clinical correlation is much like the other epithelial cell tumor, so we have put it here itself. So these are the epithelial ovarian tumor types. Okay, and out of this, as you all know, on the ovary there is fallopian tube, so quite obvious, most common is serous cyst adenoma. Among the all epithelial tumors are 90% of all the ovarian tumors, and in ovarian tumor the most common is serous cyst adenoma. Okay, it is so common that even its malignant form is most common. Okay, the another type of the tumor are germ cell tumor. From where the germ cell tumor arise? Okay, the germ cell tumor arise from the germ cell, or you can say ovum. Okay, now you know that germ cell, when it gets fertilized, then it forms fetus, it forms yolk sac, it forms placenta, and it comes from primordial germ cell. Primordial germ cell. It comes from germ cell. Now we were discussing that why. Let me take the query of Dr. Ayushi. It's a small query. I am taking it first. That ma'am, in question 29, why there is written increased ALP level? Dr. Ayushi, it is written increase ALP level. It is not always that LDH is raised. Basically, the dysgerminoma tumor has many tumor markers, out of which most common is the LDH, and it also has alkaline phosphatase as its tumor marker sometimes. Okay, okay, but as it was written that it was negative for HCG and negative for CA125, the other were ruled out. Okay, some these slight information do comes in exam. Okay, is it clear, Dr. Ayushi? Please give a thumbs up if it is clear. The you can say the other tumor marker for dysgerminoma is alkaline phosphatase. Okay, now if the part of the ovum which makes the germ cell, if it gets tumorous, then it forms teratoma. The part of the germ cell, if it gets it's tumorous, then it forms yolk sac tumor or endodermal cell tumor. The part of the germ cell which forms placenta, then it gets tumorous, then it forms non-gestational trophoblastic neoplasia or choriocarcinoma. If the primordial germ cell, from where the germ cell comes, if it gets tumorous, then it forms dysgerminoma and it is equals to seminoma of the testes. Okay, the third classification is sex cord tumor. Okay, now here the follicle gets tumorous, so it can be granulosa cell tumor, theca cell tumor, fibroma, and Sertoli-Leydig cell tumor. Are you getting, Dr. Sumit? Okay, so your question was 55 is which of the following is not germ cell tumor? So granulosa cell is not a germ cell tumor. Have you got it? Have you got it? Okay. Next question your is 50. Let me take 50. Regarding dysgerminoma, all is true. Better among all of these, only epithelial ovarian tumors, they have got the good prognosis. Okay. Now we are discussing question number 50. Okay, among all the ovarian tumors, epithelial has got the good prognosis, rest all have got the bad prognosis. Okay, is it okay? Dr. Sumit, please tell me if you have understood this fact. Okay, only the epithelial ovarian tumors occurs at the age 55. Rest all tumors occur in very young age, and I told yesterday in the class also that I have lost one of my friend because of this young age ovarian tumor. Okay, next is 49. 54 years old lady with postmenopausal bleeding. So here in all these options endometrial biopsy is there. Okay, so the best endometrial biopsy is hysteroscopy guided biopsy, which has got 100% sensitivity and specificity. Is it clear, Dr. Sumit? These are there are two endometrial biopsies given in question number 49. The best is hysteroscopy, so hysteroscopy is the answer. After that it is (47). CA125 is a marker for ovarian cancer. Here I would like to tell you that CA125 is a marker for epithelium ovarian tumor, not for any other. CA125 is a tumor marker for only for epithelium, not for germ cell, not for granulosa cell. Please make this point very clear. Today in quiz you are lacking this point. That is why most of you did wrong. CA125 is the tumor marker for ovarian epithelial tumor. Dr. Sumit, best test is endometrial biopsy. Okay? TVS is not the best step. TVS has very limited role. Okay? Next is for after 47 it is 39. 39 is vaginal metastasis. Endometrial cancer, its stage 1 is, in the endometrial cancer, stage 1 is endo plus myometrium. Stage 2 is cervix. Stage 3A is serosa and adnexa. Stage 3B is vaginal metastasis. Stage 3C is pelvic and para-aortic lymph node. Four A is bowel and bladder. 4B is distant metastasis. Is it clear? Is it clear, Dr. Sumit? Next, your question was 33. This is already, I have already told you, as this size is 6 centimeter and hormonal derangement cyst does not go up till that level. So the answer is lap cystectomy. Already we have taken this question. Okay. So now let me take another question. 19. Yes, this was a good question and it can come in exam. Dr. Karishma have asked this question. Question number 19. Beta, if the patient is BRCA positive, the chance of ovarian carcinoma is more than 50%. Okay? And if the chance is more than 50%, you will not screen this patient. You will always do a definitive test. This is not a normal patient. Screening is done in the patients who have no risk, no symptom. If BRCA is positive, the risk is 50%. Screening is done in normal population. It is very important. Vandana Verma, good morning. Karishma, have you got this concept? Both are equally risky. Okay, both are equally risky. Karishma, have you got this thing? Mamta is asking 34 and 35. "53 years post-menopausal female with endometrial hyperplasia and atypia. Better endometrial." 34 is if there is endometrial hyperplasia, it means that patient is at risk of becoming endometrial cancer. Since the age is 53 and the with atypia is also there. On the histopath, atypia is also there. So it means the risk is either it is 8%. Either the risk is 8% if it is simple hyperplasia, and if it is complex hyperplasia, then the risk of becoming having cancer is endometrial cancer is 30%. So why to make the patient live with such a high risk? So hysterectomy should be done. Hysterectomy should be done. Beta BRCA positive, Ramya, please clear your concept that BRCA positive patient is not a normal patient. Okay, let me tell you, Ramya, that if BRCA positive patient is there, okay, and the cancer is diagnosed today, okay, then the patient will expire within 2 to 3 months. Then we have nothing to do. Such a high risk is there with BRCA mutation. Okay, and cancer is going to come in the patient of BRCA mutation. 50 to 80% chances are there. Okay, yeah, Ramya, we do prophylactic oophorectomy in every patient. Please make yourself clear that screening is done in non-symptomatic. Screening is done in a non-risky population. Such a high risk, 50%, 80%, we are not going to do screening. Why to do screening? Okay? Screening is for a perfectly normal population. Okay? Okay. Next question was 34 and 35. 34, is it clear? Mamta? Mamta, is it clear? 34 was your query. 35 is granulosa cell tumor marker is, as you all know, granulosa cell, question number 35. Granulosa cell are the follicle cells, and follicle synthesizes inhibin and estrogen. So estrogen is quite non-specific and synthesized otherwise also in our body. So its tumor marker is inhibin. Okay, is it clear to you? Mamta? Shafi, your query is question number 14. Lot of queries today I was expecting. CA 125 is elevated in all of the following. Already I have made it clear that CA 125, lot of you have queries in this. CA 125 is a tumor marker beta for epithelial ovarian tumor, not for germ cell tumor, not for any other tumor. Okay, is it clear to you? Please improve your this concept. This CA 125 is a tumor marker for epithelial ovarian tumors, not for germ cell tumors, not for granulosa cell tumors, not for sex cord tumors. Yes, it is also elevated in endometriosis and PID. Is it clear? Dr. Sumit is asking whether it is inhibin B or inhibin A. It's inhibin B. But sometimes inhibin A is also done because their structure are very similar. Okay? Okay, let me take the next query. After 14, it is 27 and 23. All are markers of germ cell tumor. Already this query has been taken, Dr. Sumit. 27. All are marker of malignant germ cell tumor of the ovary except CA 125 is a tumor marker of epithelial ovarian tumor. Okay. Okay. 23 number is Most common ovarian carcinoma in children. See, epithelial ovarian tumor are common in 55, you can say 50 to 60 years age. Otherwise, they are not common. Okay. Now, what is the second most common tumor after, if we don't see epithelial ovarian tumor, what are the second most common tumor? It is benign in cystic teratoma or dermoid cyst. It's one and same name. Okay, is it clear to you, Dr. Sumit? Question number 23. Question number 20. Okay, here it is written that patient had history of ovarian cancer. Patient had history of ovarian cancer now, but the patient is presenting with smooth cyst. It means it is non-cancerous. But this, as the patient had the history and the patient age is very much same age in which the cancer develops, so you have to follow up this patient with the tumor marker of epithelial ovarian tumor, that is CA125. Observance on first option is observe. Only observing will not go. Okay, drilling of the cyst, it can be that it is a smooth cyst and it will go off. Okay, lab surgery to visualize the nature of the cyst, no dear. If it is becoming cancerous, then CA125 will rise. Okay. Okay, next is 14. This has been done. CA125 is elevated in all the following except question number 3. Most common ovarian carcinoma. Okay, in this 23 question I told you the most common ovarian tumor in children, as epithelial ovarian tumor occurs only at the age 50 to 60 year. Most common ovarian tumor in children is benign cystic teratoma, and the most common malignant ovarian tumor is dysgerminoma. Okay, so most common tumor in, so this is also question number 3. Most common tumor in children is no doubt benign cystic teratoma, but if they ask you most common malignant tumor, then it will be dysgerminoma. Okay, next is Ramya is asking 51. I think we have taken 51. Ramya, please write down if you still have problem in 51. 52. 52 is what we do in staging of CA ovary. Okay, let me tell you what we do in ovarian staging. Sumit has written it is not mentioned about benign or malignant. It is mentioned here. In question number 3 you are writing. Sumit, you are writing in question number 3. Question number 3, it is written ovarian carcinoma. In question number 3, it is written ovarian carcinoma, beta. Carcinoma means that it is cancerous. Otherwise, it would have been cyst, complex cyst. Okay. Now let us take the question number 52. Ramya query is question number 52. Okay, how we do the surgical staging. See Ramya, here I would like to tell you that when a patient comes to you in OPD with a ovarian mass or pain abdomen, and you did PA and PV and you find that it is an ovarian mass, so you have in doubt in your mind that ovarian tumor can occur, especially if the lady is 55 years old. You know that epithelial ovarian tumor occurs. Then you get the ultrasound done. Okay, then you get the ultrasound done, and on ultrasound it come out to be complex ovarian cyst. Okay, and of 10 centimeter, or you can say complex ovarian mass of 10 centimeter. Now you know that this is an ovarian tumor. It can be benign and it can be malignant. Then you get the tumor marker done. What is the tumor marker of 55 years old lady? CA125, epithelial ovarian tumor. Okay, so now CA125 is also raised. On ultrasound, it is also a 10 centimeter big cyst. Now what you will do? Tumor marker is positive. Now you will do surgical staging, right? Now you will do surgical staging. And what is surgical staging? Number one step is debulking. Debulking. What is debulking? Debulking means that you have to remove the tumor and whatever involved area you can remove. Okay, and then you have to send it to for biopsy. Okay, number two, you have to remove all the suspicious areas and send it for biopsy. These are the suspicious areas for which you have to send it to biopsy. Retroperitoneal lymph nodes, omentum, and ascitic fluid. Okay, so these are the 4 steps that you have to do during the surgery of the patient of ovarian mass with tumor marker positive. Okay, Ramya. So the options were peritoneal washings. Yes, if ascitic fluid is not present, then you send peritoneal washings. Okay. The another option is omental biopsy. Yes, we do it. Peritoneal biopsy. Yes, we do it. Because if peritoneum is involved, then we do peritoneal biopsy. But palpation of organs, we don't know. Debulking means whatever it is involved, we have to remove. So peritoneal biopsy we have to do. Okay. Is it clear, Ramya? Please write down if it is clear. Let me take another query. '57. Ovarian tumor most commonly associated with Amenorrhea. See, the menstrual problems comes with only, this is question number 57. Menstrual problems comes only with follicular cell tumors. Okay, menstrual problems only come with follicular cell tumors. And what are follicular cell tumor? Granulosa cell tumor and theca cell tumor, because you know that granulosa cell and theca cell, they collectively make estrogen. Okay, and when granulosa cell tumor is there or theca cell tumor is there, then more estrogen will be formed, leading to more endometrial proliferation. Okay, Is it clear? Ramya, please type yes if it is clear. Dr. Yushu, your query has been taken. 11, 14 and 19. Okay. 11, Dr. Ramya, it is a new search and this was a question came in INSCT, excuse me, INSCT May exam. Okay, this you have to make ratta. This is a new drug which has come. Okay, pembrolizumab. That is what I have done. Okay, as it has come in INSCT, it can come to you also. Question number 11. Now we are talking about question number 11. You have to do ratta. This is a new drug approved. Okay. Next, your query was 14. We have taken 14 already, Ramya. Next is 19. 19 has also been taken. Okay. So I think all this have been taken. Ramya is writing, in a thicker cell tumor, amenorrhea occurs. No, ma'am, then how come it's Amenorrhea? Dear, mostly it occurs amenorrhea. That is why I told you that if thicker cell is tumor is there, then or granulosa cell tumor is there, then menstrual problems will occur. As in the option granulosa cell tumor was not there, so we choose the thicker cell tumor. Okay, right? In theca cell, what happens? The androstenate ion changes into the cholesterol changes into androstenate ion. Okay, and this androstenate ion then in the peripheral tissue becomes estrogen. Okay, so if there would have been in the option granulosa cell tumor, we would have chosen. I just want to tell you this concept that the menstrual problems do occur with the granulosa cell and the theca cell tumor. Mostly high bleeding occurs with granulosa cell tumor and amenorrhea occurs with theca cell tumor. But in the option, if granulosa cell tumor is not there, then you can write there take their theca cell tumor, because other tumors don't affect the menstrual problems. Is it clear to you? Dr. Sumit is telling in Sertoli cell tumor amenorrhea occurs. Sertoli cell is something masculinization. Okay. No, let me tell you the classification of, I think there is some problem in classification. See, sex cord tumors are the tumor of the follicle cell. In the follicle, mainly these two cells are there, granulosa cell and theca cell. Sometimes Sertoli and Leydig cell remnants also are there and they get tumorous. Now you know that Leydig cells, they make testosterone. When Sertoli and Leydig cell tumor will be there, then masculinization of the female will occur, right? If testosterone is produced in a female and that also in a tumorous value, much high value, right, then masculinization of the female will be there. Okay, that tumor is known as arenoblastoma. Arenoblastoma means changing the sex of someone, male changing to female, female changing to male. Okay, okay, yes, you're right. Dr. Sumit, that in Sertoli cell amenorrhea occurs due to the high testosterone values, but Sertoli cell and Leydig cell tumors, they are not so common. Okay. Okay, if any queries left, please type in the chat box or we should close the session.